at this stage. Let's just wait more. All right, we seem to be stabilizing at this stage at 235. I would like to start. Let me give one more minute. Okay, it's growing up, it's going up, so I'm gonna wait. All right, it's still going up. Let's see, maybe at 300 we can start. All right, 250, give us, still going. All right, I think this will be the time that we can start. I want to welcome everyone that is joining us from all over the country. We normally also have people that join us from the UK, and I've seen a few people that join us from America. Welcome. If you're joining us from those countries, I'm sure the challenges that we are facing as the South African Dental Association or the Oral Health Fraternity in South Africa, that's what you are also facing in your country, and I'm sure you're finding new ways to deal with COVID-19 and dentistry as such in these very difficult times. This is the Hygiene and Coding Workstream, which is chaired by Dr. O van Schalkwyk. For those of you that are joining us on social media, welcome. I just want to clarify a few things. This webinar is an accredited webinar. You will get 1 CEU for this webinar. Those of you that are joining us via Zoom, you do not have to do anything further, but you will get your certification. Those of you that are joining us through social media, you will have to write a particular test. Now, we've been announcing this since we started. I do want to say that there is unfortunately a bit of a delay. Do not rush into the website because you won't be able to access the questions that go with this particular webinar. However, we hope that by next week, all the questions for the various webinars will be available to everyone to write. You can also inform your friends that should they want to, first of all, learn and also to earn their CEUs, they can join, they can go to the webinar in about a week today, and they will be able to watch the same webinar and answer the questions related to that particular webinar, including this one, and you will be able to get your CEU. I also want to emphasize that these webinars at the moment, during these very difficult times, we've made them available to all members and non-members. So as long as you are one of the oral health workers, you are most welcome to join us, to learn, to ask questions, to give input. We are all in this together. It is not just a few people. Having said that, the webinar will be posted onto the website within, say, immediately after we finish. And other than that, if you want to ask questions, please go to the question Q&A section and type your question at any particular time. At any particular time. The moment you've got a question, go there and type the question. At the end of the presentation, I will go through those questions and I will then give it to the panel to answer the questions. Those of you that are joining us through social media, on where we are live, please type your question on the timeline where we are live. Do not go and inbox us on Facebook, for instance, because I will not be able to see that question. But if you type it on the on the Facebook timeline or the YouTube timeline, wherever we are, please, we'll be able to get some of the questions. We hope to deal with all the questions that will be asked today. So welcome to everyone. Having said that, I would like to ask the President of the South African Dental Association, Prof. Moipilai, to say a few words. Prof. Moipilai.
Thank you, Casey, and welcome to all the participants in tonight's Hygiene and Coding webinar of the South African Dental Association. A big thanks to the Workstream team for doing this huge amount of work that continues to inform and guide our colleagues locally and hopefully even across our borders. And I just want to say that we are all in this together. And it's only through each and every one of us inputting and participating in the conversations that are currently being had within the profession that we can have a collective voice and come out of this pandemic much stronger. And with that, I want to encourage those of us on this platform who are still not members of the association. Can you please take this opportunity to sign up, because the more we are, the stronger our voice to the powers that be, and we can only grow the profession forward. Unfortunately, it had to take the pandemic to get us together, but let's seize this opportunity and work together going forward. Thank you.
Thank you so much, Prof. I will now ask the Vice Chairperson of the board, Dr. Osman, to say a few words before we go for presentation.
Good evening, everyone, and welcome. It gives me great pleasure to welcome you to this, the third workstream presentation for engagement with the members. Just a brief history, there was some background story that members submitted questions at the onset of this pandemic, and then DPCOM was then formulated into the extended DPCOM with these different work streams. The hygiene and coding work stream that is presenting tonight specifically addresses hygiene in so far as that the protocol part is concerned. We had the clinical protocol team that was developing that. This then went further to do hygiene principles and how a practice can be ready and be effective in minimizing the risk of transmission. Second to that was the coding part. The coding part was now how we could identify and look for gaps within our current coding structure and benefit structure from the schemes, how we can engage with them to be able to help members by developing codes that would actually not developing codes, by ensuring that the codes would be relevant and applicable for the benefits of which the third-party funders provide. There was a lot of discussion and a lot of engagement that has happened, and the work is far from over. One must bear in mind, this is just the beginning of the engagement. We are meeting with schemes daily, and we will definitely try and make sure that we maximize the coding so that it can be fair and functional for all. Thank you.
Thank you so much, Dr. Osman. I would like now to introduce Dr. O van Schalkwyk. Dr. O van Schalkwyk is the chairperson of this work stream, which we call the Hygiene and Coding work stream. He has given his time, the evenings, the mornings, whenever we require him to obviously work with the stream as well as working together with the other streams. Just to remind everyone, we have 4 main streams. The Dental Clinical Protocol Development stream, which is led by Dr. Swart, and we've got the Finance Relief Resourcing team led by Dr. Yvette Solomons. We've got the Mentorship and Wellbeing team led by Dr. Kasul, and of course, this particular team led by Dr. O van Schalkwyk. This team is presenting for the first time, and then we'll see what exactly is required from here, and then we'll take it forward. I'd like to hand over to Dr. O van Schalkwyk to take you through a summary. First of all, more or less, what is this work stream all about, and then what they have dealt with and what they are dealing with and what is going to happen going forward. Thank you so much, Dr. van Schalkwyk.
Thank you very much, Casey. Welcome everybody, and thanks for the opportunity to present the work that we've done up to the present. I just quickly want to introduce the panel members. It's Drs. Nadeem Osman, Dr. Michelson, Stephanie Pieters, and Fazil Mansoor. And the two other members of my committee who unfortunately are not in the panel tonight is Dr. Metsing and Dr. Jeff Beukes. I just want to quickly get my presentation on here.
He's getting his presentation. Please note that we are live on Facebook, the South African Dental Association Facebook. That's where we are live. So please join there. I also noticed, which I'm going to ask people in future not to do, that many people will actually register themselves on the Zoom and do not attend. Your registration actually blocks other people that wants to attend. If you register and you are not able to attend for whatever reason, please go and deregister yourself to free the space for other members. There have been so many members that have spoken to me today saying they're failing to get into the Zoom. And now I see that the Zoom itself, the people that are actually attending today are not to the level of 500 that is expected. So that means many spaces have actually been blocked by those who just registered and not coming. Thank you so much, Dr. van Schalkwyk.
Thank you, Casey. Can you hear me? Casey, can you hear me?
We can hear you, Doctor. Go ahead. We can hear you.
Thank you very much. Just want to make sure that I was not muted. The presentation tonight is sort of just to give us a briefing on what's been done up till now and what's still ahead and where we are currently with the process. I've tried to keep it short and succinct so that we can get to the Q&As as quick as possible. I think just to retouch on what we discussed the previous time, we're currently in a situation with dentistry, and we all know that by now, it poses an especially high-risk environment towards COVID-19 exposure, and by virtue of the fact that dentists produce AGPs, aerosol generating procedures, which comprise more than 80% of procedures in dentistry, making it a very, very contagious and risky environment to function within for everybody involved. So as a result, it was necessary to incorporate extraordinary precautionary measures within dental practices, and it's crucial to do so in order to be able to practice. So these extraordinary measures, among others, include, first of all, PPE at best practice standards, and very importantly, at the prevailing SADA protocols. And then also an enhanced level of infection control measures between patients. It's now become necessary to spend a lot more time on disinfecting surfaces, equipment, and instruments between patients, whereas in the past it was a quicker process. And then there's the financial implications of these extraordinary precautionary measures. Firstly, in the form of the additional actual cost of PPE, and then any other precautionary measures, such as equipment in the form of extra oral aerosol evacuator, aspirators, fogging or disinfecting units, and air purifiers that some practices are implementing to assist in getting the environment as virus-free as possible. And then furthermore, the cost of time implications involved due to the meticulous in-between patient infection control measures, which now takes a lot more time. We'll discuss the effect thereof, in the next slide or so. So just to summarize, in terms of the implications, suddenly practices are faced with an additional cost burden not catered for in the current reimbursement system. PPE is very expensive, and it is also extremely scarce at the moment. And it's virtually unaffordable to many practices if not funded or reimbursed, either in the form of funders or by patients or by a combination of both. If one looks at the study we did, just to give a bit of perspective on this, involving more than 90 dentists, we saw that over the period of a year, an average of 11 patients were seen during an average of 19 working days per year. That's from 1 January to 31 December, so it's very representative. And at an average turnover of approximately 890 Rand per patient per visit. So if PPE, we will show it later, the cost for PPE for AGPs, if one does it or exercise it in resonance with what the protocols committee prescribes, is 254 Rand. So if that needs to be funded out of the a clinician's pocket or out of the practicer's pocket, that means that it's 28.4% of general turnover. If one looks at dental margins featuring between 25 to 35% on average, if the practice now suddenly needs to absorb an extra 28.4% of cost, it will decimate the practice's margins. That makes it very crucial to actually recoup at a cost recovery basis, at least, the money is invested in PPE and other measures. It's going to be very imperative to implement PPE in order to ensure continuation of a dental practice. No PPE, unfortunately, no practice, for obvious reasons. The task on hand for the Coding and Hygiene Committee was to calculate, firstly, the cost of impact of enhanced infection control measures to the practice. Firstly, like I said, in the form of the cost of PPE, and then secondly, the cost to quantify in rand value the cost of clinical time lost due to enhanced infection control measures being necessary. And then to present these findings to funders as well as patients in a scientific manner in order to be afforded consideration towards reimbursement by funders. And then crucially important, a consideration towards allowing balanced billing to patients for shortfalls between funding and actual costs incurred for PPE and other measures at practice level. Experience has taught that although we are relatively optimistic that the schemes may be forthcoming in assisting, they may not do that to the full, and that costs that's not covered by any schemes would need to be offset by patients at the discretion of the clinician or the practice, and for that balanced billing is going to be a crucial aspect. And then lastly, to determine coding to be implemented in this regard was the last function of the committee. So just quickly, if one looks at the cost implications of PPE, there's a wide spectrum of affected areas. Many people think it's just a surgery if you talk to the public. It actually involves reception, the auxiliary staff in terms of CSSD and cleaners, the patient, and then the operating clinician and dental assistant. Just quickly, if one looks at the implications there in a bit more detail, receptionists these days don't wear makeup anymore. That's now been replaced by masks and a facial shield. They need to wear head and shoe covers, and they need to practice enhanced surface control or disinfection within their working area, use of hand sanitizer for them and patients, and then very importantly, a screen. It's highly recommended to have a screen between the receptionist and the public. The auxiliary staff, whereas in the past it was not necessary, they now suddenly also have to wear a mask and a facial shield and head and feet covers and plastic apron. The patient now has to wear the same foot cover, yeah, head cap, eye protection, which is crucial in the form of goggles to seal off the eyes, mouth rinse in the form of hydrogen peroxide 1% or povidone iodine 0.3 to 1%, and then also to have a body cover. In the form of perhaps a plastic apron or a drape, as opposed to the standard conventional bib. Dental assistant, head and shoe cover, FFP2 or N95 mask, depending on the category of service delivery, a facial shield, a disposable gown, or a clean, disinfected, reusable gown as per protocols, plus a plastic apron. The same goes for the dental clinician, for the dentist, or the therapist, or the oral hygienist. If one looks at the additional infection control measures that need to be implemented in terms of the extra disinfecting that's needed now, it says that the surgery needs to rest a while to allow droplets to settle on surfaces, after which one needs to go in intensely and then disinfect those surfaces and equipment and instruments, etc. in the surgery, and this will significantly reduce the number of patients, the time lost that can be seen during a day, from an average of, we worked out, calculated, of 11 to 8 patients a day, and there's a slide talking to that. And unfortunately, the harsh reality is that these measures will always certainly remain in place for some time to come. So in terms of the lost time due to extra infection control measures necessary, the study was conducted in a generalist dental practice environment. Unfortunately, we do not have data for specialist practices, but they are as much affected. And one can see that pre-COVID times, an average, as I said, of 11 patients were seen. Amidst COVID now, that number is reduced to 8 patients per day. Now, that is only if there's a maximum capacity prevails. If the demand is still there, if you've got a busy practice, because we found that there's a massive drop in many instances of demand at this particular point in time. Patients prefer to stay at home and stay away as far as possible from dentists and even medical GPs, some of them operating at less than 50% of normal capacity. So at a minimum of 15 minutes extra cleaning time, and that's a minimum, I need to stress that, in between patients, 8 patients referring, and assuming, like I said, the demand remains optimal to allow for 8 patients during a normal working day, the practice will lose as much or a minimum of 120 minutes clinical working time at, as our study indicated, the 21.16 per minute. So the total RAND value for those 120 minutes can amount up to 2,539 per day, which is a significant chunk of money out of a day's earnings. So in terms of progress to date, the committee is determined. We've done the cost of the PPE. It's been calculated, and 3 scenarios will refer. One will be, there will be a differentiation between non-aerosolized procedures. Now, we worked out or calculated at a cost of 53 Rand. And as I say, these need to resonate with the protocols, the protocol committee's protocols and recommendations and guidelines. And then there's aerosol generating procedures where significant enhanced levels of PPE need to apply. And for that, we've calculated an amount of 254.24 Rand. And then in terms of surgical procedures within a sterile environment, we're just busy finishing or completing the calculations thereof. And then very importantly, we've established collaboration with the protocol committee, which was a good thing because, you know, we then could work closely together to make sure that the cost of the PPE and what's to be used under the different scenarios resonate then with the clinical protocols. So the cost of the time loss calculation was done, and that is a very good indicative value of time lost in the interest of perspective. And in coding, we've decided, and we've had quite a bit of debate around that, to keep it simple. You know, it's better to use existing codes. To create any new codes can take up to 12 to 40 to 24 months in a scheme environment. And it's a laborious process. So the best and the simplest way would be to do an adjustment, an upwards adjustment on existing codes, sterilization 8110 and 8109 infection control barriers. It's already there. So the challenge is to negotiate a better dispensation in terms of those 2 codes. In terms of scheme interaction, we've already had, or SADA's already had a meeting with the first major scheme, and follow-up actions after that meeting is in progress. Further meetings are scheduled with other major medical schemes starting tomorrow. And then we've got representation of the protocol committee on the negotiating panel in the form of Prof. Piet van der Vyver. We're glad that he's part of the negotiation team to be able to answer any questions and to enlighten on any protocol issues. And then lastly, there's extremely tight timelines. You know, there's a immense urgency to complete this task as quick as possible to start ensuring that the PPE, the cost of PPE, can be claimed by all members. And that's the end of it. Thank you very much.
Thank you very much, Dr. van Schalkwyk. I think what we will do now, is there any member of the panel that wants to add anything quickly before we open for questions? We did expect that today we should be able to go and sleep early, hopefully. The other day we went on for nearly 2 hours, 20 minutes. Okay, anyone from the panel that wants to add anything? You can just unmute yourself and speak. No, all right. I think let's go straight to the questions because I think that's where the biggest issues are gonna come from. All right, the first question is it within the scope of the dentist to take a swab for a coronavirus? Who's gonna take that question? Is it within the scope of the dentist to take a swab for coronavirus? You can just unmute yourself and tell me you're gonna take the question and answer.
Question, maybe if I can come in there. You know, the taking of swabs is usually confined to places where the patient's totally isolated from the practice environment. So most practices would, in the interest of safety, as soon as the patient during the screening process shows any symptoms or signs, they would immediately be isolated, not allowed within the practice, and then as the swabs are taken at a designated destination, usually a laboratory or hospital or so. In terms of whether a dentist can take it or not, yes, a dentist, by virtue of the fact that dentists operate within the oral cavity, there's no reason why dentists cannot take swabs, but in a controlled environment, that would be advisable.
Thank you so much. The second question is, we are, sometimes I will add my own ways to get it right. We are repeatedly told not to touch the mouth, nose, and eyes to prevent contracting the virus. What about the ears? Can the virus enter the body through the ears? Dr. Deveji, does anyone know about this? Prof. Piet, if you can hear me, if you're available, you can please also assist in some of these clinical questions, if you're available. Thanks. Who wanna take this question? And by the way, even the members of the people that are attending, if you have an answer, you're most welcome to push it in through here, because we don't claim, and I don't think this team claims to know everything. Nearly some of the things are still being learned with regards to this virus. Dr. Deveji's question, anyone? Sorry, I can't see. So if you want to answer the question, just raise your hand or just unmute and talk. Okay, I don't see anyone answering this question.
Sorry, Casey.
Yes, Prof?
Casey? Yeah, I think we really haven't heard much about the ears, but the common information around is the mouth, nose, and eyes. But the thing to be prudent about is we just need to limit touching our facial structures so that we don't inadvertently transmit the virus. So any precautionary measure that we can think of, we need to be aware of. But at the moment, I'm not aware of any literature that's quoting transmission via the ears, but precaution prevails.
Thank you so much, Prof. The second question from Anonymous: it has taken SADA 50 days to provide us with a code to use for the PPE. We in the interim looked incompetent in front of our patient, not knowing how to bill an invoice for PPE. However, in the meantime, your panelists have spent so-called sleepless nights working on PPE protocol. Is SADA proud of itself? So in other words, a critical question to the work that is being done by the organization. I'm going to ask the chairperson of the Dental Practice Committee to deal with this question.
Thank you, Casey. I am very proud of SADA and the people that has worked on the protocols to set those protocols there, because this is something that should have been done by statutory bodies, and nothing was forthcoming. So yes, that is very, very something to be proud of. Secondly, there's no code that we can create. We can create a code within half an hour for PPEs, but there's no guarantee that any third-party funder will pay for that. So what SADA has for very long promoted is that we look at your practice structure and you work out your own fees. We've got a decalc available that helps each practitioner to work out what his cost is and what he wants to earn on that. And no one has, or no, I don't want to say no one, but very little dentists has used that program to help them. So that is a rhetorical question to Anonymous is, have you done a analysis of your practice to see what your cost is compared to what medical aids pay out, and have you adjusted accordingly?
Thank you, Dr. Swanepoel. The next question is from Dr. Omar. Does the cost of PPE include the cost of appropriate disposal? So in other words, cost in terms of disposing, whether it's gowns, all of those things that we're talking about. Does that cost that we're talking about include that, Dr. van Schalkwyk?
I think maybe Prof van der Vyver can answer this one. As he did the review of the, if he's online, as he did the review of the protocols, which included that.
I'm not, okay, I'm not so sure if I see him. There he is. Prof, do you want to deal with this question?
Yeah, we didn't deal with this in the main protocol document. We did discuss it. And I think that you will just have to upgrade your current service with your service provider. It can't be a lot of money. We had long discussions about this, if we should create a code for it or add it to the code. I don't think medical aids are actually going to participate in this venture to dispose PPE. At this stage, we've gone for looking at getting quality PPE into your practice. It's a very good point. I think when we carry on negotiating, where the committee carries on negotiating, we will bring this up and see if we can get some funds for it. But at this stage, I think the priority is to get PPE and get everyone working. And because we've already got agreements with those companies, it will just be a supplement fee.
Thank you, Prof. Next one, you say the estimated cost for PPE is 254 per patient. According to protocol, it is way more. Replace mask every patient. My gowns and disposables amount to over 600 per patient. I appreciate the effort SADA has made, but after 50 days, there's been no progress. I have been doing emergency work for over 50 days. I'm running at a loss. When is there going to be any changes? So I think this is about the actual cost. This doctor, Anonymous, says he thinks the cost is about 600 per patient, as well as when are the changes going to occur. So I think let's deal with this question. We want to take it. Dr. Swanepoel, Dr. Okay, Prof, you can start.
I think Anonymous has got a very good point. In our document, we've created essential minimum standards and an aspirational standard. And we've just recently, last night on a meeting with this code committee, changed it to the recommended standard. So you will have to practice between essential, minimal essential, and recommended. So Anonymous is quite right. The PPE is quite expensive. You can probably run up to 1,000 Rand per patient. You will have to establish the level. And I think we have to accept that third-party funders is not going to pay the full amount for this. So we'll have to start asking patients co-payments. Otherwise, you'll have to limit the type of work you're going to do and not to put yourself and your staff at a risk. But I don't see in the near future that for any profession in South Africa, medical, dental, that third-party funders is going to come up with such a high amount to pay for PPE.
Thank you, Prof. If there's anyone that want to add, please just indicate by your hand so I can allow you to add commentary. Dr. Foster says, please could you put up the slide that showed the PPE requirement for staff? Dr. Foster, I think for the benefit of time, can I ask that you please immediately after this presentation, give it about 30 minutes to 45 minutes. You can access the whole presentation and you can go to the particular slide that you are looking for, just for the sake of time, if you don't mind. Dr. Bezuidenhout, I suppose this is, has it been decided who is going to fund the COVID test every 2 weeks? Dr. Bezuidenhout, I can answer your question by saying that we still are asking for this information to give you the correct information. I believe that by Friday there will be a communication from SADA giving you this information. This was also asked in the last webinar. Dr. Gilman, Prof. Gilman, a compliment to Dr. van Schalkwyk for keeping his presentation factual but succinct. So there you go, Dr. van Schalkwyk. You are being applauded for not making it all long-winded and confusing at times. Thank you, Dr. Gilman. Prof. DRC from Dr. Makanji. DRC has started paying for 8110 for non-extraction procedures. Surely medical aids can adjust their values for 8110 and 8109. Do you want to deal with this, Dr. van Schalkwyk or Dr. Swanepoel, or even Dr. Nadim Osman? Dr. van Schalkwyk, do you want to start dealing with this?
I will answer that, yes. Thanks. As I've explained in the presentation, we did quite a bit of head scratching on which codes to implement, and after some deliberation, we thought it's best to come up with the existing the 8110 and 8109 codes, and then request the medical aids for as long as it might take to do an adjustment on that. And that will keep it easy. It's very quick to do it on their systems. It's very quick to do it on virtually all practice management systems, and that was the rationale behind the thinking.
Thank you, Dr. Joseph. If the practice employs a dentist and a separate hygienist, and the patient sees both on the same day, one after the other, are we able, to charge for the PPE for the dentist and the hygienist, that is twice? Who wanna deal with this question? In other words, if a patient comes to the practice and they have to see the dentist and then see the hygienist in the same practice, in terms of PPE, is the practice going to charge, and are the schemes going to pay for both the hygienist PPE as well as that of a dentist PPE? I think if maybe I may take this question at the moment, we don't know, because that's part of some of the negotiations. I think it's a good question that has been asked. It's one of those things that we still have to deal with and negotiate and ask that they carry on in terms of this, Dr. Joseph. The next question is, are your panelists aware that most medical schemes do not pay for rubber? Yeah, Dr. Swanepoel?
Just on that question there, if a patient, we're looking at the codes 8110 and 8109. If a patient sees a dentist and he sees the oral hygienist on separate on the same day in separate time slots, they are allowed to charge 8109 twice and 8110. According to our coding book. Medical aids pay differently, but they are allowed to charge that double.
Okay, thank you, Dr. Swanepoel.
They will be able to charge.
Thank you, Dr. Swanepoel. So this will go, I suppose, basically what you're saying is, since we currently can do that for other procedures, even for PPE, we should be allowed to charge for that for both the dentist as well as the hygienist. Anonymous, are your panelists aware that most medical schemes do not pay for rubber dam for fillings? What is SADA doing about this? I think it's Dr. Osman and Prof. likes this. It's one of the questions that we like. Can I ask Dr. Osman to deal with this?
Yes, we are aware. SADA is very aware that certain schemes do not pay for rubber dam done other than for endodontic treatment. In our meetings with the coding protocol, clinical protocol group, and with the schemes, we have strongly advocated the using scientific background supplied by the...
Dr. Osman?
Okay. Right. The panelists are very aware of the current coding limitations on the code 8304, and SADA has spoken to schemes and will continue to speak to schemes regarding allowing that code to be used across the board for all procedures, including restorative procedures, due to the fact that the scientific studies have shown up to a 98.8% reduction in aerosol generation. So SADA is advocating very strongly for the use of 8304 in all procedures, not limited specifically to endodontic procedures. And that is a fight we're going to take on.
Yeah, maybe what I should do at this stage is just keep a summary of some of the issues that we're discussing with the medical aid schemes. So number one, we're dealing with the PPE negotiations. Aligned to that, we are dealing with what codes to use that needs to be augmented to cover for the cost of the PPE. Then, as the protocol clearly indicated, the rubber dam is going to be our future. We are now speaking to every medical aid scheme to provide for rubber dam for restorations, which currently, as Dr. Osman has indicated, is limited to endo. So we are dealing with that. On top of that, we are also saying where medical schemes feel they are not able to fully cover all these costs, maybe they should allow dentists to actually do balance billing, because this is allowed by the HPCSA. So I would say those are 4 angles that immediately we are actually pushing through with the medical aid schemes. The next question from Dr. Paul Matai. Dr. Paul Matai is the Vice President of the South African Dental Association. He says many medical aid schemes have put limits on the codes we can charge for at this time, and also require us to spend further time trying to motivate for 8104 consultations. Are schemes being engaged in this regard? Dr. Osman or Dr. Swanepoel? I hope you guys can hear me. Okay. Dr. Osman?
Okay. It is understandable that there is a lot of restrictions placed on practitioners in performing certain procedures simultaneously on a patient during a visit. As part of our another angle that we are approaching is that limitations on number of procedures done per visit should be removed in order to maximize the use of PPE, especially considering the cost factor and the scarcity of it. It does not make sense to use PPE and then get the patient back for another visit using another set of PPE. So SADA is engaging with schemes to remove all restrictions on procedures allowed to maximize time and the benefit of wearing PPE.
Thank you so much. The next question, I calculated the cost of the PPE for the dentist and assistant to be very close to 400. Prof, if you are available, I would like you to take this because I know that this was discussed even last night. I excluded the face shield in this calculation as the face shield can be cleaned. I think Prof as well as Dr. van Schalkwyk. So let me read it again. I calculated the cost of PPE for the dentist and the assistant to be very close to 400. I think that using the diagrams that we have already provided in the protocol, I excluded the face shield in this calculation as the face shield can be cleaned. How did you get the rand value of the PPE? Can I ask the two of you to maybe deal with this? Prof first, or wanna go? Prof, you are muted.
Sorry. I can give a breakdown unless Uli wants to do it.
Please go ahead, Prof.
Okay. So what we've looked at is firstly for the dental assistant, we've calculated fees for a percentage of the facial shield. So you can't charge the facial shield every time. Uli has kindly worked out that, say for instance, the shield will be usable for 2 months or 3 months. He's worked it back to per patient fee. So they'll allocate the fee towards that. Then the assistant we divided procedures into a non-aerosol and an aerosol generating procedure. So I'm first looking at this stage now at, let me just go back quickly, at a non-aerosol procedure. A non-aerosol procedure, I apologize, I talked about the facial sheet. Let me just start over. So let's first talk about non-aerosol generating procedures. There the assistant will have a 3-ply mask. She'll have booties on, foot covers, and she will have a mop cap on. That's the minimum requirement that she should have. If you look at the dentist for a non-aerosol procedure, he will have a 3-ply surgical mask on, he'll have foot covers on, and he'll have a mop cap on. That was where we calculated the 54 Rand from per procedure. If we go to the aerosol generating procedures, it changes drastically. Then the assistant will have a part fee for the facial shield. We'll upgrade a mask to a FFP2 or N95, disposable gown. Although this is a big problem at this stage, companies has elevated the prices of these equipment or these garments tremendously because they are seeing us, or they elevated the prices for people in an emergency situation. So say for instance, someone goes into a building or in a company, they will wear one of these facial gowns for the whole day. And that's why they inflated the prices. They don't understand that in dentistry, with AGP procedures, we'll have to change this gown after each patient. So we've allocated the amount at this stage of 50 Rand to that. This is a non-sterile garment. We can push the price up, but I don't think medical aids will look at that price. I got a quote this afternoon from Beukes for a company that we thought will help us, 187 Rand for one gown. 187 Rand. So I don't think we can be, we don't have to be unrealistic that a third-party funder that at this stage pay us 24 Rand for 8109 is definitely not going to give us 300-400 Rand for a disposable gown. To finish up there, she'll have covers, foot covers, and a mop cap. And the total amount allocated for that is in a region of about 110 Rand for the assistant for an aerosol generating procedure. If we go to the dentist, you'll have a partly fee towards the facial shield, N95 or a higher mask. The price is slightly changed there. Also a disposable gown, we're sitting with the same problem. Foot covers, mop cap, and then we also included a few other disposable items into that. And that calculates to about 120 Rand. So that's for aerosol generating procedures. Now, I think we have to understand that we can ask for anything. We can ask for 600 Rand. We can ask for 800 Rand. But are we going to get that? If we're currently sitting at 24 Rand, I think if we double or triple, or they listen to us at the end and we get to 254 Rand, as Uli stated, I think we will have to be very happy with that and work around that. Uli, maybe you can comment on that.
Thank you very much, Piet. The template was devised in a way that's quite user-friendly. So from a SADA perspective, I think the template provides that you can actually input exactly what you've paid as per invoice into that template, and it will automatically then calculate the total costs. Where if you pay 110 Rand for your gown, you can input that, and it will automatically then change it. So I'm sure that SADA will release this to all members, and then they can use it themselves. Because the dilemma was, should one do it on a per practice basis? You work it out and you do a complete cost recovery, like an M plus a material factor fee, but it becomes a bit of an administrative nightmare. Or should one go in with an average value, because the schemes have already done their homework? You know, talking to them, we already know they've got data, and they will obviously whittle it down to the lowest possible extent. So, like Piet says, one should rather go in perhaps with realistic aspirations. But I'm sure that if you can prove that you actually pay more for whatever reason, and because there's a myriad of different types and different suppliers doing the rounds by now, then if you can prove a cost recovery situation, that's where the balanced billing situation will come in. So if you're not exploiting the patient but doing a neutral cost recovery, I'm sure you've got a good argument to put on the table.
Thank you so much. So basically what I think Oli is saying is this spreadsheet will be available for individual practices for you to input the cost, because as he indicates, what the committee has done is to use averages. Now, averages don't work for everyone. So we don't know where you procure your PPE, and we are not going to force individual practices to procure their PPE from one particular supplier. And we're not going to say this is how much we should pay, because that will also amount to issues around the Competition Commission, and we're not going that route. This one from Dr. Naidu, I think it's just an addition to the question on the role that the EMA play in terms of the transmission. So he just indicated probably the histology of the mouth, nasal cavity, and eyes makes it susceptible to the virus. Thank you for that. The next question, if a dentist, orthodontist, oral hygienist follows all the protocols suggested by SADA and treats his patient essential and non-essential, what gives the medical aid the right to refuse payment? They are, however, still taking the patient's subscription during this time. We've dealt with this issue, particularly with the first big scheme that we met last Thursday. Dr. Osman, I think this is one that you can deal with and dispense of. Can you quickly comment on this one? Your mic is on. Unmute yourself.
Thank you, Casey. If the member follows all the protocols suggested by SADA, it does not give any right to any scheme to refuse payment. At the end of the day, the member is treating the patient and has a right to be reimbursed for that. The only issue comes in at what rate the medical aid will provide a benefit, and therefore we must also be advising our patients at what the cost is. In our discussion, there was also a suggestion that we actually created a form where you and the patient can actually sit down and go through each item and explain to them, this is what it costs you. By understanding, even the HPCSA ruling, if you give the patient informed financial consent, they cannot do anything, they cannot take you up on that matter, because at the end, the patient is knowing what to pay and his expectations are not unnecessarily abused.
I think what I want to add, just again to give meat to this whole scenario, please note that the protocol are very, very clear in that they say we're looking at giving a guideline on the 80% of the work that you do, but the 20% relies on your professional skills, knowledge, expertise, and experience. And this is one of the things that we are again raising with the medical aid scheme to say, if you must understand, we give a protocol, we give a guideline, but someone is going to be a trained professional, will be in front of that particular patient. And when they use their own gumption and judgment based on their professional expertise, you should allow them to charge for the work that they have done. We are pleased that the first one that we have met, and we'll release this in a combined document, actually indicated that as long as they have provided for such benefit, even during this time, if you do the work that you believe need to be done and it looks fine, they will pay for it. And we hope that that will be the same for the majority of the medical aid schemes that we are engaging with. I know for sure there's one that I got 2 letters from 2 members from Thursday who have written to you indicating that they will not pay for anything outside of emergencies or outside of the protocol. Now, if you get those emails, I may encourage you to please email us at clinicalsupport@sada.co.za, and we will specifically deal with that matter with the medical scheme on your behalf. I want to also add, at this juncture, SADA, as long as you're in the oral health profession, whether you're a member of SADA or not a member of SADA, you will be assisted. So please do make use of the facility that we have in the office. The next question, it says, I agree with trying to up fees for 8109 and 8110, but I don't have much hope schemes will comply. Why can't we use code 9099 and put PPE COVID-19 as a descriptor, even if it is? I do apologize. I seem to have lost my internet there. I do apologize. I'll go to the next question straight away so we can move on. So I was saying the use of 9099 and put PPE COVID-19 as a descriptor. Now, maybe let me answer this question if you allow me. The problem with 9099 is that we know that we can only use that for 6 months. And COVID-19 is going to be with us and around with us for quite a long time. The first medical aid scheme that actually we have spoken about and we have had a meeting with, they are of the opinion exactly how we think that one of those 2 codes need to be upped. So we do believe, Dr. Erasmus, that they will all actually come to the party. Yeah, I think that answers that question. But yes, I do understand what you say. Next question from Dr. Bezerenhout. Do we have any idea of a timeline about when the medical aid scheme will answer of what they will pay or not, so we can answer our patients? Maybe let me answer that. We don't have the final date, but we hope that by Friday, some of the medical, this coming Friday, some of the medical aid scheme would have come back to us with some answers. It's a hope, but again, we can only tell you once we have received from the particular medical aid scheme. It could go for next week, we don't know. We are hoping that, for instance, with the one that we met this on Thursday, we indicated the agency, and they said they definitely are going to be working in the background while we provide them with further information, but they would like to get back to us much quicker. The next question, it feels like the aim of SADA and its committee, to pander primarily to the medical aids. Why isn't the primary function rather to create a valid value for PPE and disinfection for dentists, and secondly, to push the schemes to agree? By not agreeing to pay a legitimate fee, including the time the disinfection, etc. takes, the schemes would be putting their members' lives as well as ours at risk. Anyone that want to comment on that? Dr. Sonnepoel or Dr. van Schalkwyk or Dr. Osman?
I can comment on that. The preamble of the new document that we're going to present with this committee to the medical aid states that point very clearly, that we cannot treat patients at a substandard because it puts the patient's life, the staff, and the dentist himself or the operator's life in jeopardy. So hopefully they will take note of that, and when we negotiate, that they will comply to that point. But it's written by Blackie and Howard Gluckman very strong in the beginning that they have to take note about safety, that we are concerned, not just about disinfection here.
Thank you, Prof. I think the following question from Dr. Skuman is that in terms of the breakdown of 254, that's what Prof. van der tried to do, Van der Vlever tried to do earlier on, but we will make this available as we've indicated in terms of the spreadsheet that you can use. The next question, during level 5 lockdown rules, I only saw emergency patients and I was not at my practice otherwise. My practice is 45 minutes from my home. As normal practice hours was not applicable during level 5, I charged code 8129 to cover my call out costs to my practice. DRC refused to pay code 8129 together with code 8101. What am I to do regarding their refusal to pay? Excuse me. Doc, please contact us through Jeff, clinical support. It's an email, clinicalsupport@sada.co.za, so that we can deal with this case on your behalf with the said medical aid scheme. And everyone else. Template, I suppose they're talking about the one that we're using for calculation. We're going to make it available on the website once everything is sorted in terms of the formulas and the rest. It will be available and downloadable from our website, and you can then save it in your laptops or your computers. Dr. Fourie, are there any chance that the government will get involved in funding subsidizing PPEs to the private sector? Does anyone have an answer to this? I'm not aware. Okay, Dr.
Okay.
Dr. Osman.
Regarding PPEs from the public sector or from government, as we all know, the Solidarity Fund has been set up and there's a lot of contributions to that. And there's a consortium of businesses called Business for South Africa. They are procuring PPE and distributing it through certain suppliers. The initial phase was first to supply all the government hospitals and government facilities, and they have sort of sorted all that out. Subsequent to that, Business for South Africa is going to then make PPE available at reasonable prices through a few national distributors. There is a document that was released, and it will be posted on the SADA website if it hasn't been already. Regarding this also, one must also bear in mind, in this time of crisis, there are many opportunistic people that are taking advantage of the need for PPE. As you know, you can see, if I look across, or we have looked across the market, a overall disposable coverall, the lowest I've seen is 48 Rand, up to 250 Rand. Obviously, there are quality issues. One must also try and also not just purchase the first person that comes along and look for something that is reasonable and at good quality. Because I see figures here of people paying 200, 300 Rand for PPE, for disposable coveralls, just one item. there are many small middlemen that have now sprung up, and the Competition Commission is taking these people or these traders up. I mean, a few big companies have been also taken before the Competition Commission. So one must exercise caution and also try and make sure that they buy the correct stuff at the correct price. Conversely as well, there are many fake products or counterfeit products or substandard products that have been brought into the country, and it's difficult for members to differentiate between the two. So the best advice is to stick to reputable suppliers that have been serving the profession for a long while, as they do have the profession's best interest at heart, and they are not just some company that's trying to make a quick buck. Thank you.
Thank you, Dr. Swanepoel. I do apologize if I'm breaking. For some reason, I seem to be now having an issue with my internet. If I do break, I'm going to ask Dr. Swanepoel to carry on as a chair while I get myself sorted. I want to quickly go to the questions on the Facebook. Dr. Koch, he says, please also take into consideration the 50% material cost increase. So this is for you, Dr. van Schalkwyk. And Dr. Douglas is asking the question, and I think it's an important question we might need to answer or deal with and get back to the members quickly. So what do we charge now in terms of the value for 8109 or 8110? What do we charge? Dr. Swanepoel, do you want to maybe deal with this?
Casey, just repeat that question.
The question is, so what do we charge now? Value of 8109 and 8110. I think there are two questions loaded in this. It's for PPE, whilst we are negotiating with the schemes, what do dentists charge for PPE that they're currently using? And I think that goes back to a comment that was also indicated earlier on. Do they charge even the code? Do they charge code 8109, 8110, 110, sorry, and what amount do they charge? Are we able to answer this or not?
Casey, what I'm going to say now is my personal opinion on this, and one has to have a look at it. I think in the interim, what Dr. Erasmus alluded to earlier was the code 9099, that we, at least if practitioners are practicing, that they use that code for now, and explaining to the patient what the cost is so that they can pay for that. We are, what I'm afraid of is that we are going to create something that the medical aids are going to pay more. And Prof. van der Vyver alluded to it earlier, that medical aids is not going to come in and rescue practitioners on this. I think this is a prudent time for practitioners to break away from the employers, and namely the medical aids, and start working for themselves. But in the meantime, I think what should be done is use the code 9099 and explain to the patient what PPEs you are using and what your cost to that is, and let them be aware of that. If the medical aid doesn't pay for it, they have been informed, and the payment can be generated from the patient themselves.
I think maybe what we can do to push this as well, whilst the negotiations are going on, Dr. Swanepoel and the rest of the committee, is to ensure that a communication leaves out to the medical aid scheme as soon as tomorrow, to say, until such time that there's an agreement, we have advised our members that they will use 9099 to cover the cost of PPE. Every individual will charge it according to how they see fit and reasonable, but it will be on 9099. I think that answers quite a few questions that I see here. And Dr. Gopi says there is no evidence that transmission can be through ears so far. I think this we have dealt with. And then another one says, I'm going to skip the ones that seem to be repeating some of the things that we have covered, if you don't mind. The issue of the cost from Dr. Gafour, it has dealt, now we have dealt with that. And then there is a comment from Dr. Douglas, maybe you can deal with this, the three of you or four of you. Face shield should be disposable. Comments on that? face shields should be disposable? Simple, according to Dr. Douglas.
I think I'll comment on that. I think in the ideal world, face shields could be disposable. Some of the face shields, you can actually buy a protective strip that you paste in front, and after you've seen the patient, you can remove it. But even in that situation, you still have to disinfect the face shield because of the aerosol that can go in from behind. I think firstly, it's a cost implication. Secondly, I think depending what disinfectants you use, I think for a limited time, you can disinfect that facial shield. If you can't do that, then probably all our plastic in our practice should be covered and we can't disinfect it. I don't know if he's aware of evidence that maybe the virus penetrates in there, or I don't know why he makes the comment, but I think at this stage, my answer would be that you can properly disinfect it, depending on what you use.
Maybe we should invite Dr. Douglas. You've got my details. If you've got further information relating to what now Prof. Pieters indicated, please send me an email and I'll forward it to Prof. and the team to have a look at that, and maybe it may be something that we can learn. Dr. Jordan, can cross-contamination take place between brown paper bags where reuse of masks are stored in a box? Can cross-contamination take place between brown paper bags where reuse of masks are stored in a box? Does anyone know the scientific issues around this?
Maybe I can comment on that. I think the idea is that you put the mask in a bag and leave it for 3 to 4 or 5 days, and then you go back to it. So I think you can contaminate it if you remove it prior to that time period, because then there could still be active virus. But if you place it in a bag and leave that bag untouched for, say, a week, 5 to 7 days, and then take the mask out, I think there's very little risk, because then the virus should have been, if it's gone on your virus, it should be gone on the bag. But if you prematurely swap those masks around or go into the packet and put a mask in or get something, then it becomes a problem.
Thank you so much. Are all dental waste now classified as hazardous waste because of the virulence of the virus? Do we know? Prof?
I assume it would be, especially if it's an AGP procedure. It's contaminated.
Thank you. What are the indications from the third-party funders? Are they positive or negative about the extra cost of PPE? I can safely say they are positive. By positive, I mean that they will definitely increase or cover part of our cost. The question mark is how much. By how much is that going to be covered? So far, after we've written to them, all of them want to meet with us. Hence, I believe by the end of this week, we would have met with the big five. And some of them may start to get back to us by hopefully this weekend to say this is what they want to do, and we can take it from there. Is there an update on a code for telephonic consults? General doctors and all allied health professionals have one. Why not dentists? Dr. Swanepoel, do you want to deal with this? And maybe Jeff, Dr. Michelson?
Casey, it's Stephen speaking. What we said is that we use the code 8104 for this because it's for a specific procedure. It has been updated from the HPCSA. We are looking from DPCOM, looking at the code for the telephonic consultation, but at this stage, it's recommended that we use code 8104.
8104. I think that will cover it. Jeff, do you want to add anything there, or are you fine?
No, I agree with that, Jennifer.
Thank you. What role has been played or guidance given by HPCSA, if any? I'm not quite sure this question relates to PPE or relates to the telehealth, telemedicine. So it's very difficult to answer. Or if it relates to PPE, my thinking is that they all will obviously go with us where we say we need to protect ourselves, our staff, as well as the public or the patients. So I'm sure they will have no issue with us pursuing to get the cost of PPE being recovered for these procedures. But I'm not quite sure what this question is all about. The next question is medical aid practices are under severe financial strain at the moment, and it is not possible for us to spend money on all of these additional PPEs. What will be the consequence if the full protocol isn't adhered to? Not that we don't want to comply but some of us are simply can't afford. I've got an answer to this, but let me hear what the members of the panel want to say. If someone does not comply to the protocol, what are the consequences? Okay, should I shoot? Let me shoot so long. Dr. Sonepul, you can add. The issue is, in every profession, there are standards that are expected. There are minimum standards that are expected. And these minimum standards are not only there to protect you as a dentist, but also to protect the patient. Now I'm gonna, in this case, if you as a dentist, for instance, decide not to follow the protocol, I'm just gonna give you one consequence. If you don't decide not to follow the protocol and something very bad happens, like a transmission of a virus or a COVID-19 case in your space, and a patient says, I have contracted the virus through Dr. So-and-so's practice, and they take you to the cleaners, and you cannot show what standard or acceptable standards you have followed in order to make sure that that kind of transmission does not happen, you may lose the case. When you follow the standard, you are protected because you can show that this is what is recommended, and I can tick it to the T that I followed the standard. So that's one area to assist you. But I don't know if Dr. Sonepul or anyone else want to add.
Casey, Prof, if you can answer first, then I'll talk.
I just wanted to mention that I understand the question, and I think Alistair McKelvey has dealt with this issue as well. He also mentioned that it's very difficult for a patient to prove that he actually got the virus in your practice. But what Casey said is very important. The first thing that the court will look at is, what is your standard of care? Do you have proof for purchasing PPE? And also interview probably other patients to see what level of care that you provide. And then you will be found guilty. It doesn't matter whether that patient actually got the virus or not. So what Casey mentioned is very, very important. The second thing is that if you probably not comply with these rules and you just go blatantly on the way we did before, and you transmit the virus to a few patients, they will identify you as a node of transmission. And then there will be severe consequences from a legal point and probably from a HPCSA point of view towards your practice.
Thank you. I think this is a comment. Dr.
I just wanted to say the most obvious consequence there is that you and your employees are going to contract the virus.
As well.
Most likely, yeah. This is a comment, and I think I'll just read it for the benefit of everyone, and I'll leave it there. The bottom line is most practices rely on third-party funders, and SADA has created an unrealistic protocol for the average dentist. This protocol now makes us liable for not complying. SADA has essentially given us a rope to hang ourselves. I think I'll leave that as a comment. Why does the patient need PPE when it is their own aerosol we are protecting them from? This is, of course, assumed that they won't catch anything from us, as we'll be wearing good PPE. Anyone want to comment on this question?
Casey, I can come in.
Yeah.
The reasoning behind your patient wearing the PPE the moment they walk into the practice, before they get to your clinical area, they are moving through your practice. So in that, the idea of a mask is not to protect you from contracting from someone else, but more to limit your spread of your germs. That's why you give the patient a surgical mask. That's why government policy is to be in public with a mask. By them moving through your practice, they can spread the virus if they cough in your reception or if they cough in the passage along the way to the operatory room. So I think that is where the justification comes for the patient to wear PPE before they get to the operating room.
Thank you, Dr. Osman. Next question. In which bin should disposable gowns be disposed of? General waste or red bag?
I would assume the red bag.
More so if it's an aerosol generating procedure.
There we go. Thank you. Screening has been gazetted as a PMB, so as of last week. As dentists, can we claim for the screening of our patient? If so, what is the relevant tariff code for this? Anyone knows anything? Dr. Swane?
Yeah. For screening, you're gonna have an initial cost of for a thermometer, and there's no extra cost in doing the screening as such, because screening is just to complete the questionnaire and getting the patient's temperature. So I don't think there's a cost to that.
Thank you, Casey, can I just refer back to the person that asked the question? When they say screening, do they mean just the form screening or the actual swabbing? If they can just post a comment and differentiate whether it's just the screening or the actual swabbing, because there's a difference if that is swabbing involved.
Dr. Swane, Dr. Osman, I think let's assume both. So let's try and answer both of them if you've got an answer, so that we don't go back and forwards. Assume both and maybe provide an answer to both.
Okay. If it is the swabbing, there was a workshop held by the NIOH. They did have a workshop where they were offering training for dentists to be able to do the swabbing. And if I'm not mistaken, there is a code. If you just give me a few minutes, I'm just going to try this, locate the specific code for that, and I'll come back, unless Dr. Michelson has it on hand.
Thank you. Dr. Michelson, do you have it on hand?
It's muted.
Jeff, you are muted, eh? Jeff? Okay. Jeff, you are muted.
It's better now.
Can you hear me now?
Yes.
You can hear me enough for me to say I'll have to look it up. I don't know it offhand.
Thank you. All right. This is a complimentary from Dr. Omar. Thank you all on the SADA panel for the great sacrifice of time and your kind devotion to the profession. Hope your efforts bear some fruits and you put backstroke money. We hope that, Dr. Omar, this will actually come to assist all of the oral health professionals. Thank you so much for that. Dr. Jaglau, can we charge patients for PPEs if medical aids don't fund them? I think as we've indicated, the HPCSA allows you to do balance billing. The problem is some medical aid scheme, like Discovery, if you do balance billing, you know that they are going to pay the rest of the cost to your patient, and you're going to struggle to get the money from the patient. So we are negotiating for them to, particularly during this time, to allow for this to occur. But at the moment, some of them, they don't. So you just need to be very careful. And I think this is something that Dr. Sonepul may want to add a commentary on this.
Casey, thank you. Yes.
Dr. Sonepul? It's like it's frozen.
Can you hear me, Casey?
Yeah, go ahead.
The important thing here is inform. If the patient is informed prior to doing that, they can never, they can't complain about it, because if you've informed him prior to the treatment, this is the cost for PPEs, your medical aid might not pay for it, so you're going to be liable for that. There's no reason not to charge that.
Thank you. We have heard up to our ears about rubber dam. Medical schemes don't pay. Why doesn't SADA help the average dentist? SADA, as usual, has a begging bowl in its hand with regards to funders. Let me deal with this question, because I think sometimes members need to appreciate the environment which we work in. Majority of the dentists that are attending today, they, as it is, have contracted their services into various medical aid schemes. So we cannot wish away medical aid scheme when the majority of our colleagues are with medical aid schemes. And therefore, SADA has to negotiate with this medical aid scheme. And I think it's unfair to say we are going there with a begging bowl. We can decide, we can literally sit and decide this is the cost and not even negotiate with the medical aid scheme. but that's not going to help the average dentist that someone is referring to here. And I think it's unfair to make such a statement. We are trying our best as an organization to help those many dentists whose services are contracted to medical aid scheme. In terms of the rubber dam, we have dealt with it already earlier on, so I'm not going to repeat, except that we, particularly because the protocol speaks about that, we are going to ensure that we negotiate that there is a benefit allocated for a rubber dam that does not limit it to endo, but we can do it in restorations. Thank you so much. The next question, has it been discussed and given approval by HPCSA to ask a patient to ask patient co-payment for PPE? Dr. Sonepal or I think Dr. Osman, the two of you can deal with this. Dr. Sonepal?
Casey, yes, it's the same. As long as there's informed consent, the patient has been, the PPE cost has been explained, yes.
What I do want to add though is, please remember, depending on the medical aid scheme the patient is coming from, you may be creating a secondary issue, like I indicated, the first medical aid scheme I mentioned. When you do that, they will not pay you the money, they will pay them the balance of that money to your patient, and then you have to actually now do debt collecting. So just be aware, but that's an issue that we are trying to deal with. How much should I be charging for PPE and disinfection from tomorrow? I'm not interested in what the medical aids ultimately pay. What should I charge? What can we advise this member, Dr. van Schalkwyk?
That's Casey. Like I said, I think, if you get the patient's consent, like Dr. Swanepoel's been saying, and then you do a fair cost recovery. In other words, there's no motive to exploit the patient in terms of trying to profiteer out of PPE. Then you're safe.
Thank you. Thank you so much. The next question from Dr. Gela. While waiting on medical aid to decide on PPE remuneration, we have had to charge patients to cover costs. Will networks that don't allow balanced billing be able to penalize us for this? I think that is something that we're going to have to take with the medical aid scheme. It will be unfair, but Dr. Gela, I'm going to take this and put it on record for a discussion with medical aid scheme. Dr. Desai, can you please update us on your deliberation with Discovery Medical Aid Scheme? The only thing that we can say, if we've had a meeting and it was a fruitful meeting, and there's quite a lot of things that will probably come out of this meeting beyond just the PPE, but we are not able to say anything until the final discussion, hopefully this week. And obviously, the first thing that they would like to do as a medical aid scheme is to make that announcement, and maybe jointly with SADA, whatever the case may be. So we are not able to announce, but safe to say that it was a positive meeting, really positive meeting. We won't get everything that we want, but definitely we will get, there will be some solution to this. Dr. Anonymous, I would like to know how many of you on the panel have practices that are contracted to medical aid. If it's less than half of you, then I don't think you can fully emphasize the general dentist out there. I'm not quite sure how to answer this question, but I think safe to say, in the various, you must understand the panel that you see here is not the complete panel to start with. There are many other members that are not able to attend today. And the panels, whilst they work as separate entities, they feed back into other panels and the discussion is held jointly, like Dr. van Schalkwyk indicated, that this committee worked closely, for instance, with the protocol development team. So, and from where I'm seated, I know that there's quite a lot of general dentists in the various space. There are those that are not, those that are contracted and those that are not contracted. But what I can safely say is that in the whole of the membership of SADA, majority of the people are contracted in to medical aid schemes. Dr. Makanje again, whenever I do any denture repair, impression, and delivery in the afternoon, I never get paid for the second set of 8109 and 8110 on the same day. So basically, Dr. Makanji requires some solution. It's a general question, not necessarily on what is happening now. Jeff, Dr. Michelson, are you able to deal with this? Your mic is muted.
Yes, I can. It's unmuted now. 8109 is chargeable per visit, irrespective of whether there's more than one visit on the particular day. So it could be 8109 times 2 at the initial visit if the assistant is involved, and there's absolutely no reason why it can't be charged again at the delivery time.
May I suggest, Dr. Makanji, just Jeff, mute your mic, please. May I suggest, Dr. Makanji, to send us an email with the details, and we can try and help you to discuss this issue with the specific scheme. A lot of us practices in areas where you have to practice at medical aid tariff because the majority of patients just can't afford to pay any extra money. So if the funders won't pay for the extra costs incurred with these PPE guidelines, these practices simply won't be able to stay in the open in these conditions. Let me just emphasize what we have said. Number one, currently, as from now, use 9099 to charge for PPE. We cannot give you an amount because we all get we all procure our PPE from different suppliers, but as long as it is ethical and it is reasonable, use that code to claim and put the necessary descriptor. All of the medical aid schemes, they do know that PPE is going to be charged one or the other. We've written to literally every single medical aid scheme in South Africa, small and big. So they are definitely aware of this. And this is something like Dr. Osman indicated earlier on, it is a fight that we are willing to take going forward with the medical aid schemes. So please use that. And then depending, if you are struggling and you are sending these invoices and you are not getting paid, please, that is the right time to contact SADA through clinical support at sada.co.za. Dr. Erasmus, two problems is preferred providers can't balance. And one problem is Discovery, who is spiteful and will pay that this is not acceptable. Still, they do it. And it was asked at National Council that DPCOM should look at this matter with a question mark. So I think, I'm going to leave this with Dr. Swanepoel to deal with that matter. Thank you. Dr. Chetty, which they don't have. They publish a list of PPE, etc., but haven't received. I'm not quite sure what this question is. Does anyone understand this question?
No.
I don't understand. Please, Dr. Chetty, can you retype this question? Surely rubber dam must be obligatory. Dentists must be seriously pushed down this road. I think Prof. Pieters is an advocate for this, and this is the reason why I've indicated we are busy now negotiating strongly, and I think this is now coming for the fourth time. Dr. Botma, how will the time lost between patients be reimbursed? I think Dr. van Schalkwyk, you dealt with this, but just quickly deal with it again.
Yes, Casey. At this stage, we were able to do an average quantification of the time lost, but it's a subjective type of scenario. That's where the balance billing component probably comes in, because where the schemes are gonna pay for that over and above the cost of PPE remains to be seen. So it's a cardinal part of our armamentarium when approaching the schemes to negotiate, to actually demonstrate to the schemes the loss of income due to enhanced infection measures and time lost. So we do incorporate it in the negotiations, and with the hope that there may be something forthcoming out of that.
Thank you so much, Dr. van Schalkwyk. This comment from Anonymous: where schemes don't agree on what SADA has deemed as recommended protocols, which is based in science, can the association approach the Department of Health to mediate? Thank you for the hard work you have put in. Many do appreciate it. And thank you so much, Dr. Anonymous, for that. The answer is yes. Look, the first call is our protocol. As we've indicated in the other webinars, are basically accepted by the HPCSA. HPCSA falls under the Department of Health, and where we have such issues, we will definitely rope in whoever we need to rope in to discuss. At the moment, not a single medical aid scheme has indicated they don't agree with our protocol. Dr. Omar, can we please have a hard copy via email of Dr. van Schalkwyk's presentation? Thank you for that request. We won't be able to send it via email. What I can say we can do is that tomorrow by close of business, it will be available under resources where you can download the presentation. So we're going to load it on our website, www.sada.co.za. So the PowerPoint. Thank you so much, Dr. Omar. Anonymous, from the previous webinar, which reusable respirator was recommended by Prof. van der Vyver? Prof?
The respirator I recommended was the one from 3M, the half-face mask. You get quite a few different models, and then you can attach closed filters, 6038 or 5038, onto the half-face mask. The problem at this stage is there's very limited stock. The company that you can try and source them from is Pinar and Bros. They've got branches all over the country. You probably have a better chance getting them from an outside branch than from the Joburg or Pretoria branch. But they sometimes get stock in from other branches. But at this stage, 3M has indicated that they have no shipment landing probably in the next 2 months. So if you want to secure one, you have to hurry up and buy as many filters as you can.
Thank you. One of the things that we are going to do in the next week, hopefully, is to bring in the Dental Traders Association of South Africa so that we can deal with these shortages and the stuff, and you can, as members, also indicate where the struggles are. Thank you so much. Dr. Lombard says, what about the use of washable or sterilizable surgical gowns as opposed to disposable gowns? Will this not lower the cost of PPE drastically, he asks. Anyone want to deal with this? I think, Prof, you may be a good person.
I think Uli can deal with that because he worked it out in his document. So I think he's got figures at the end as well. It's a very good suggestion.
Yeah, Dr. Schalkwyk?
Yes, the minimum standards for AGP, the minimum standard says or stipulates that as long as a clean and disinfected gown is worn in between patients, doesn't necessarily say disposable gown. For aspirational standard, it is a disposable gown. So I've done a calculation. If you take a washable gown and it lasts for 15 washes, and you cover it with a plastic apron, as a minimum standard, that will suffice, and it will definitely be cheaper over the longer term.
If I can maybe comment on that, because people are struggling at this stage. My technician, and I don't know what the company's name is, my technician has secured a company that sells disposable scrubs for 150 Rand a set. So you get a head cap, shoe covers, and a jacket and a pants for that price. And this is a very, very good option if you're going to really relook at reusing them at this stage. You can contact me privately if you need information.
Thank you so much, Prof. My supplier charges 300 per disposable gown and PPE routinely AGP without mask. That is over 300 for myself and over 300 for my assistant. How are we going to cover this cost, especially with no split billing allowed?
Maybe
but,
I can
anyone that want to ask?
I want to comment on this because I want to applaud Stephen for his previous comment that he advised people that the time has come that we have to charge patients for some co-payment fee or, and I understand the problem with balance billing, but I think this pandemic and probably for the next year, we are not going to survive in practice if the patient doesn't contribute towards some of these costs. It's just not going to be possible. And I know for some practices, it's very difficult to ask patients for co-payments. They practice sometimes in a poor area. The patients has got limited income, but there's not going to be an easy answer to this. And I think the message I want to give you tonight is that don't depend on the medical aid to give you all the money back. You will have to start making plans. how difficult it might be. I am making plans in my own practice because some of the stuff I also cannot afford, and I can't charge my patients more for PPE because our infection control measures was already at a high cost and at a high level to the patients. So you have to start looking carefully at this. I don't think you must put all your eggs in one basket to think that in the next 2 months, the medical aid is going to pay for all this PPE. You'll have to make a plan.
Thank you so much. Dr. Coetzee? Yep.
I just want to say something. The members must remember there's a difference between balanced billing and split billing. Balanced billing is allowed by the Health Professional Council. Split billing is not allowed because split billing means that the patient receives 2 invoices, and that is not allowed. If a patient receives 1 invoice with your cost and the difference between what the medical aid pays and what their co-payment is, that is legally acceptable.
I think that's a very, very important point because I saw another question just now on this. Let's not confuse the 2 terminology. The one that is allowed, just to repeat, the one that is allowed by the HPCSA and you can do legally, although some medical aid schemes don't agree to it, is the one where you have 1 invoice for your total expenses on the patient. And then from there, the patient, you know how much the medical aid is going to pay, and the balance is paid for by the patient. That is legally allowed. Because I've seen even other questions on Facebook lately where people are asking whether balance billing is allowed or these kind of things. It is allowed. The split billing is where it is not allowed by the HPCSA, where you produce 2 invoices, 1 for the medical aid cost and 1 which is still a balance, but it's separate, because basically what they're saying is they want to see the full cost that is actually being spent on a patient, even though they don't pay the full amount. So please remember the split billing as well as balance billing. Balance billing is HPCSA allowed, it's legal. Although some medical aid scheme don't agree, particularly Discovery, don't agree to it, but it's legal. Okay. Thank you so much, Dr. Coetzee. May I have the patient sign a form that they are willing to make co-payments towards PPE prior to treatment with the cost of the co-payment towards PPE? Again, it will refer to you. Yeah, let me actually leave to someone to answer this. Dr. Sonepul, I think you can deal with this. And Dr. Osman, I think the 2 of you are good at this one.
That is informed consent. If the patient has been informed prior to treatment, it is allowed, yes.
Thank you. Well done, team. But I think it is a pity that the view of the negotiating team is to ask for reimbursements less than the actual cost. The result will be payment of even less than the amount asked for. So in other words, I think if I understand the sentiments of this doctor, is that if we ask for a little bit higher amount, we're probably going to end up with more or less where we should be. But if, according to him or her, if we ask for something lower, we're going to end up even lower than what we're asking, which we think is a reasonable amount. Are there any comments on this? Because it's something that you're just going to note.
I think most medical aid actuaries looking at the total cost of PPE and of disinfection products, and they know more or less what they're going to pay from start, what they can afford. Well, they can afford a lot more, but what they're willing to share with us. And I think if we come in at a very high price or a very low price, we probably will still get the same amount, more or less. I don't think it's going to make a major difference. I think this committee will ensure you that I'm not really part of, but dealing with them, that they will probably fight for the highest amount they can get. And I think it will be on an ad hoc basis with each medical aid. If we go into a meeting and we see that they are open towards things, we will discuss, obviously, time lost between patients at a higher level. No one is just going to go in there and say, give us the minimum and let's walk out of here. I'm pretty confident that this team will get you the best value for money out of this deal that we'll negotiate.
Dr. Singh, hi, just a comment. PPE should be a prescribed minimum benefit, PMB, and third-party funders should be forced to pay for it, or those with nominated practitioners should provide it so their members can be treated. Dr. Osman, maybe you want to chat to this. Has this been discussed in terms of trying to make this PMB at the national level, where we are sitting for discussing PPE with the Department of Health? Has it been discussed?
According to my knowledge, no discussion has yet been reached to make it a prescribed minimum benefit. Prescribed minimum benefits have specific terms and conditions, so maybe the wording is incorrect, but I'm sure that the Department of Health will definitely take into consideration the need for PPE. I will engage with them when we meet again, and as soon as we have some input, we will forward it back to the members.
Thank you very much. Has SADA reached a decision yet on matching Nomad's offer to sponsor PPE for dentists in difficult circumstances? The answer is no. Sorry?
We're going to keep on asking.
What is it?
No, but
answer. Yeah, no. It has not happened. I think there is certain events that has happened in the past few days, and I believe that the discussion now will be reached very soon. I'm sure I will contact Prof on this one. What I can say may be linked to this, where we are involved, there are two areas we're involved in terms of PPE at the national level with the Department of Health and SAMA, as well as our discussion with, because I know there's an email that came before this meeting, so maybe I may answer this, where we are involved with the PPS. PPS at the moment have indicated to us that their stock has arrived. So very soon, again, I cannot give you the exact answer, but very soon we should be able to inform you that you can now get the free PPE in terms of the partnership that we have with PPS. I don't know if Dr. Mansoor might want to add anything on that particular development. Dr. Mansoor, if you are still there.
Hi, Casey, thanks, yeah. So by this week, PPS will give us finality, but what they're looking at is 2 packs of 5 N95 masks and 2 face shields, one for this per dentist and assistant. They'll be distributing it through the Alpha Farm chain, so the members will have to register once the PPS template or portal is up and running. We'll inform them accordingly. They can register their interest, and PPS will have it delivered to the closest Alpha Farm, closest to their practice.
Thank you so much. I hope you can hear me, because I see there's an internet disconnect there. All right, so as much as maybe we have not necessarily given the feedback to NOMET, we are not sitting on our laurels. We are actually trying to work on the other side on how using partners or working with partners, we can assist you as members. And by the way, this the PPS deal or incentive, it means you get it for free. You will apply online and it will be delivered to you. Thank you so much. Dr. Fester, looking at the work rate at present in my own surgery compared to a few months ago, the medical schemes should definitely save a lot of money as far as dental benefits are concerned. Shouldn't they use these savings to sponsor PPEs? Surely it is also to the benefit of the medical schemes to keep dentistry alive in South Africa in these trying times. What is your view? And I think let me put this way, we agree on that. We actually have raised this issue in a meeting with the first medical aid scheme that we to consideration, Dr. Fester, so thank you for that. I commend Dr. Swanepoel for pushing to get dentists to break away from medical aids and getting patients to pay something themselves. A small start, but will lead to a bigger change. Agreed with you, Dr. Anonymous. For now, if we ask the patient to cover an extra cost on 8109, 8110 while negotiations with schemes are going on, one schemes have hopefully agreed to increase the cost. Would we be able to ask medical aids to reimburse patients to the difference they have paid? First of all, remember we've just agreed that for your PPE, use 9099 with a descriptor. So let's try to be consistent. Let's use 9099 for the time being. But to answer your question, we hope that once they've agreed, yes, they should, it should follow that whoever has been charged these fees in terms of the patient, it should be reimbursed to those patients. So you need to encourage your patient to keep the receipts accordingly. Dr. Fester again, during the clinical protocol webinar, the subject of house masks was touched, especially because of recycling. Could you elaborate on that? I remember this was a question that came in, and then there was a clarification because we were not sure what half masks were being referred to. And then Prof then spoke a little bit about the 3M half mask. So I'm not quite sure what the elaboration is all about. Prof, do you want to quickly say something?
I think we've discussed it this evening as well.
Yeah.
Maybe what I can add is that in long term, it can save you on costs, because if you buy 2 of these masks, you can alternatively disinfect them properly. And with 2 filters, you can probably go a month without changing them. So they become very cost effective. The initial cost for a half-face mask with 2 filters will probably be about 650 Rand and each. And then you can use them probably for the next month or 2, if you have 2 sets of filters. So from a cost point of view, it's a great investment compared to what we're currently paying for PPE. If PPE's prices comes down and N95 or FFP2 masks come down, then obviously it will balance out.
Okay. Thank you so much. I see the Chief Executive Officer of SADA here. He calls himself the Chief Entertainment Officer, Dr. Kisun. Good to see you online. I recently had a large pharmacy group make up the 1% hydrogen peroxide mouthwash at an exorbitant price of 60 Rand per liter. Can we recover some of this cost, or is it literally water down the drain? Question mark, question mark. Anyone want to deal with this? In other words, can we recover this cost? That's basically what he's saying. And maybe even Dr. van Schalkwyk can come in here. The question could be: is this catered for in terms of the work that you have done?
Yes, we did actually provide for. We took the price of povidone iodine that's available through retailers, you know, as a mouthwash per wash, and it came out to about 9.70 Rand. The hydrogen peroxide is cheaper, especially if you acquire the peroxide and you do your own dilution. Just be careful that you do it correctly. But in terms of quantifying that, I'm not sure.
Thank you so much. Are material, gowns, caps, etc. sufficient if you are unable to obtain disposable gowns for aerosol generating procedures? In other words,
they are fine as long as you change them after AGP procedure. You can't wear them the whole day.
Thank you. Does the cost estimate of AGP include a new N95 mask per patient? Studies have said we can reuse an N95 if properly disinfected. Dr. Swart now says that SADA says we have to dispose of every N95 per AGP, which increases the cost. So that's what basically my understanding is. That's the calculation that we have now presented to the members. Does it include a new N95 mask per patient? If what he understood Dr. Swart saying is correct.
Can I answer?
Yeah, go ahead, Prof.
In our calculation, we provide for AGP procedures for a new mask every time. So you have to realize there's a lot of debate about the second part of the question about reuse. So if you remove the mask, you can probably put it in a brown paper bag and use it in a week's time again. But it's important to note that between patients, you have to have a new N95 mask. No one says you have to throw that mask away. Although the more we read, the more we look at literature, there's huge debate about how to disinfect these masks. At this stage, in my opinion, the best way at this stage that I could find is hydrogen peroxide vapor to disinfect it. Heating the mask up in the oven can change the filter potential. There's lots of chemicals that's not recommended. So the brown paper bag is probably your best option, but then you have to have quite a few masks to recycle for the first week.
Thank you, Prof. Can washable surgical gowns be used and washed to save on disposables?
We've answered that.
Yeah. Dr. Swanepoel, this is for you. I find the reply by Dr. Swanepoel for my telephonic consultation code question answer satisfactory. How can we be told to just use 8104 because there's no teleconsult code? If that is the case, then by that logic, if a medical aid doesn't cover something, we should just build another code. Is that what SADA is instructing? And I think Dr. Swanepoel and Dr. Michelson can deal with this question. Maybe can I start with Dr. Michelson, because we released a communication on this issue. Dr. Michelson?
Thank you, Casey. After the HPCSA condoned the use of teleconsultations, we wrote to a couple of the big medical aids, and quite frankly, we got no reply from them about teleconsultations. But there's absolutely no reason why a dentist shouldn't be able to use code 8104.
Thank you so much. Actually, that should be enough answer, because as much as normally when we recommend something to the members, we also send the same communication to the medical aid schemes. So that should be sufficient, unless Dr. Sonepul, you want to add something? No? Okay, I'll carry on. Maybe that's why SADA should be actively involved in helping financially with their own funds. It's the moral thing to do, show you have skin in the game. We are grateful for what you are doing, but you now need to move your talk to the next level. Medical aid practices are not going to survive. We don't know, I think, how long this will last. Absolutely, we take your comment, and I can tell you it's taken very seriously. You will get some answers very soon. Dr. Krisenger, what specs are advised when it comes to non-contact thermometers? I don't think we dealt this. Did we deal with this in the protocol itself? I don't think so. Do you want to take this?
Specifications.
Yeah. Sorry, just repeat that, Prof.
I said not the specifications as such. We haven't dealt with that.
Yeah. But what can we say, Dr. Osman?
Currently, there's a flood of non-contact thermometers in the market currently. Some are counterfeit, some are not very effective. But I think you won't go wrong if you just have a CE or a seal of approval from any of the technical authorities on that. It's a reputable company that should suffice. One can also do a sort of benchmark testing once receives the thermometer by just pointing it at various surfaces with different temperatures, just to see if it gives a different reading. There's a video going around to show that one thermometer, you just dismantle it, it gives random readings no matter what it's being pointed at. So exercise care and caution.
Thank you. Dr. Jackson, where do you get the red bags for disposing PPE, and where do you dispose of the red bags? Anyone? Anyone knows the answer? Yeah, Dr. Osman?
The red bags basically should be supplied by a medical waste disposable company. Most practitioners are aware that they should have medical waste collections, and they will be issued with a certificate of compliance once it is disposed of. So if you are running through a medical waste company, they will supply those red bags.
Dr. Gelman, I fully agree. That's what we did with the last webinar, where we had to cut. Even this webinar is going to be cutting in the next 5 minutes. Thank you so much. We agree with you on that comment. Dr. Pestana, if we are to recoup the 2,500 Dr. van Schalkwyk said we will lose per day, surely all tariffs payouts should be increased by medical aids. Just a question. Anyone want to deal with this? Basically, all tariffs, not just PPE, should be increased by medical aids. Anyone to comment on it?
I think we can ask them. We can definitely ask them and see what their opinion is.
Chair, that's exactly what we're trying to negotiate with the medical schemes.
Okay, thank you. I would appreciate if we maybe, in terms of the questioning and all that, we keep names out. Like this one. So I'm going to say DRC is not happy instead of mentioning names. DRC is not happy at all with dentists charging PPE. Can SADA prioritize discussions with DRC that members are not removed from the network due to charges in circumstances now with COVID? I agree with you, Dr. Anonymous. In actual fact, Jeff is going to tackle this issue already this week. We have received 2 letters that indicate that there's an issue with this. So we definitely are going to deal with this for you. Dr. Bezuidenhout, In Gauteng, the Department of Health are doing tests for COVID-19 essential services provided. Have there been any discussion with them to do this at no cost for dentists? Dr. Bezuidenhout, no, there's not yet a discussion. Please, can you send me an email on a separate platform? So just send me an email so I can make contact with you and understand where you get this information, and then we can see what we can do. Thank you so much for that. Dr. Chetty, yes, I think Dr. Chetty is repeating. Sometimes I don't know. Dr. Chetty is repeating that question was cut off. Milner's Dental have published a list of PPE that they are selling. We have placed orders, but to our disappointment, they haven't received stock. This is negatively impacting us. I think this is one of the things that maybe what I will do. Like I said, I'm going to bring in the Dental Traders Association, and maybe we can bring in a the big few 5, 6 suppliers to come on this platform, so we can ask some of these questions and they can answer directly to you guys, because I mean, I cannot answer on their behalf. But I saw, Prof, did you want to add something there? Did you want to make a comment or not? No, thank you. Dr. Sullivan, don't you think it's finally time for South African dentists to be brave enough, set their own fees and let the medical aids pay what they will and be answerable to their members? You know, if I can comment, when I arrived at SADA, in my first meetings, I said, why? I used the analogy of a bread. We make bread based on specification with all the ingredients that is required. And if you understand, a bread maker normally put a price based on what they have used as ingredients to that particular loaf of bread and how much it weighs. And they put a price. When I go to buy the bread, I don't say to them, I'm willing to pay for this bread. I'm willing to pay 20 cents for this bread. You ask the maker or the shopkeeper, how much is that bread? And they will say to you, it is 20 Rand. You don't negotiate, you actually pay 20 Rand and take that out. This is one of the things that when I came to this profession, I was absolutely shocked that we have allowed over the years the medical aid scheme to dictate to us, including dictating to us not to do what is allowed by law. For instance, balance billing. I think it is shocking. I think it's not acceptable to me to see a medical aid that says, if you are going to balance bill, I'm going to pay the money to the patient. I want to say this, and I'm sorry to go off track, but I want to say this. Most of our dentists today, they employ receptionists and dental assistants, but particularly receptionists, who spend 80% of their time working for a medical aid scheme. It is actually not your duty. It's not our duty to do pre-auth. That is the duty of the patient. And we are doing this, and we are paying the receptionist to do this work. And even the pre-auth is not worth the paper it's written on, because you get the pre-auth, at the bottom there it says, well, there's a possibility that, you know, they don't guarantee that they will pay for this. You do your work, you spend 50,000 Rand on the patient, they leave and go home with good teeth and health and everything. 6 months down the line, you get the same medical aid scheme that gave you the pre-auth, indicating that, no, we made a mistake. We want to get the money out from you as a dentist, not from the patient. And I think this is shocking. It's not acceptable. And I suggested, I remember, and I want to put this here because I keep on hearing this. In my first year, I put a challenge. I said, if I were to suggest to all of you as dentists to say, let's determine our pricing, and anyone who do not want to align to that pricing, we're going to tell them we are not going to we're not going to accept their medical aid cards. We will treat the patients, but we're going to ask the patient to pay in cash. You know what happened? Only 10% of the people in that room said, we agree with you. The rest is, but you know, we can't do that. We can't do that because the majority of our patients belong on medical aid scheme. So I agree with you, Dr. Anonymous. I think it is time that we do something. I really think it is time that we tell these medical aids that we are sick and tired of being pushed around and that we will determine our own costing. And this is something I would love to be part of it. And if I can get enough people here, we can work on this and we can start telling the medical aid what we are worth or what the dentists are worth. Thank you. I wish to place on record that SADA did not. Thank you.
I just want to make a comment, okay? Really, that is great leadership as being the CEO of SADA. And I think this comes very strong through this webinar tonight, that the quicker we stop negotiating with these people, the quicker as a group we can actually negotiate better fees. You know, everyone asked on this webinar, why don't you ask the medical aid more money? Why don't we get more money? But we will never get more money if we don't stand together. If you look at the Ophthalmics Association or the Orthopedic Association, they get better fees because they all stand together and say, we will not treat patients for this fee. And if dentists is not going to do that, we're never going to progress. So I really thank you for your kind words, Casey. I'm actually amazed, and it's actually a privilege to be on this webinar tonight.
Thank you. I wish to place on record that SADA did not get Discovery Key Care to pay for code 8110. It was achieved by a single individual who took it upon himself to collect signatures and petition Discovery. We thank him. We agree with you and we thank him. Anything that helps the profession, you know what, it's not about, it came through Prof, it came through Casey, it came through anyone. So we appreciate, the more we work together, the better. And for me, what is important is the more we can say these are the problems that we are experiencing as dentists, and we pull our resources together, our minds together, the better. So we thank him, and I believe it's a him, so we thank him. Thank you so much for that comment, Dr. Anonymous. The next one, besides the regular PPE, I'm spending 150,000 on a hydrogen peroxide fogging system for the day end, a misting system using hypochlorous acid between patients, an external vacuum system, and a UV light. I'll be increasing my fees across the board by 2%. I'm not interested what the medical aid think about this. Why should any one of us? I think you summarize some of the issues that we have said. Absolutely, go for it. Dr. Kutse, for AGP, must the gown be a sterile surgical gown, or can it be a disposable non-surgical gown?
It could be a disposable non-surgical gown. It doesn't have to be sterile. The only time you need a sterile one and being disposable is if you're going to do surgical interventions. Dr.
Swanepoel, we are well aware what split billing is, but as you can see, SADA has made zero progress with discovery. These are exceptional circumstances, so SADA needs to promote split billing and explain circumstances to the HPCSA. Do you want to comment on that, Dr. Swanepoel, or just note it?
Just noted, Casey, thank you.
Thank you. You are currently in negotiations with PPE. Would it not be a prudent time to negotiate higher fees for next year? We get a measly 4.5% increase yearly thereabout. All expenses increase by 10% plus an average. Any progress on a gazette? I'm not so sure which gazette, but let me tell you this, through the DPCOM, every year, some medical aid scheme, they ask us to give input to their benefit structures. So this year, what we would like to do, because every year we have submitted, we have invited members. And again, this is one thing that shocks me. I get maybe one letter out of over 6,000 dentists or dental practitioners that we send our request to, one or two letters every year. I've just, for instance, received this week from GEMS. They want us to give an input. Very soon they're going to send us an official letter. So what we are planning to do through DPCOM and the office is we are going to have another meeting like this where we can collect, let everyone hear what everyone is struggling with, and let us collect that information for benefits proposal, and then we can take it through to medical aid scheme. The next one, Dr. Lobster, if we use code 9099 for PPE, do we put it on medical aid liability or patient liability on the account as the medical aid won't pay for it? We want to deal with this question? Dr. Swanepoel, Dr. Osman, Dr. Swanepoel?
Casey, you put it on medical aid liability, and if the medical aid doesn't pay, then the patient is liable.
So that means you must do that beforehand to explain to the patient that you are going to charge for PPE, you're going to put it on medical aid, but they need to agree that should the medical aid not pay for this, that they will pay. I think that's what Dr. Swanepoel is saying. The next question regarding the respirator half mask, there is a recommendation that these masks are for industrial use and should not be used in dentistry. Any thoughts? I'm going to take 3 more questions and we're going to stop. And the rest will be answered in the Q&A that we are compiling. Anyone, I think, Prof, you want to answer this one?
I tend to differ because most of the people using PPE at this stage on FFP2 and FFP3 is actually for industrial use. Coming back to the half mask, the filters, there's a variation of filters that you can use. The filters, the 6038 we're using is actually indicated for the Ebola virus. And then you can even get a better filter that's indicated for gas that is far superior compared to an N95 or even an N99 mask. So I think the key point here is if the mask is approved and if it's good quality, then it definitely applies to dentistry or medicine. If you look at most of the COVID wards in Italy and in the US at this stage, they're all using the 3M respirator mask with filters in most of the highly infected wards.
Thank you, Prof. What about the cost of masks for taxi transport and for PPE for cleaning and reception staff? This should also be included. If I understand this question is, it should be paid for by the medical aid scheme or as part of the cost for the staff that are using public transport.
Uli, you can maybe comment on that?
I think what we've done is we've already included the cost of PPE extending beyond just the realms of the surgery and going to reception. So it's a good point. We can include it, and see whether or not we're successful.
Thank you. I'm going to ask these 3 questions together because I think they go together. Is 3%, so just allow me to ask all of the questions, then you can answer. Is 3% hydrogen peroxide vapor enclosed container for 20 minutes sufficient for disinfect a mask? And the second part of this, asked differently by someone, how do you dilute hydrogen peroxide mouthwashes and where can these be bought? And the last question, I think is the same, where do we find hydrogen peroxide vapor for mask sterilization? That will be my last big question.
Can I answer that?
Go ahead, Prof.
Firstly, I want to just add on to my previous answer that I actually forgot about. A very effective method to sterilize your N95 mask is UV light. There's quite a lot of these UV lights around. You can use a company called the Cleaning Medic where you can rent these lights and it's very, very effective. I failed to answer that in the first place. Coming back to the hydrogen peroxide, the only system creating vapor at this stage is a system called Makhubele that is quite expensive. Someone elaborated to it previously in the webinar. It's probably about 100,000 Rand for the system. I'm not sure if you can create hydrogen vapor in a holder, for instance, and if that will be sufficient. I think the articles at this stage refer to a proper system that creates hydrogen vapor. To dilute it, I don't have a lot of knowledge on that, but as far as I know, the best way to dilute it is with distilled water. And then the other question was, what was the third question on hydrogen peroxide? I forgot that.
Where do we get it?
You can buy it from pharmaceutical companies. Some of the companies that sell chemicals have it available. In fact, I saw a post recently that they say that the cheapest place to get it is from a swimming pool shop. They have lots of stock and you just have to dilute it when you purchase it from them. I think they sell it in a 5 or 10% solution.
Thank you so much. Actually, this is good. Most of the questions or comments downstairs are just in support of what it is. Dr. Crick, can you send me an email?
So, can I just get back to the hydrogen peroxide?
Yeah.
Pharmaceutical companies, you get it at like 10 volume, which is equal to 3% hydrogen peroxide. If you dilute it 1 to 2, then it comes to 1% dilution.
Thank you so much. Dr. Crick, please send me an email. I'll provide Prof. Piet's email to you. Dr. Mansoor, you seem like you wanted to say something? Or was this when you were typing? Dr. Mansoor? No. Okay. If that's the case, we actually, Dr. Mansoor?
It was when I was typing, so yeah.
No problem. Thank you so much. That's it. I think, guys, we are at the end of our meeting. Thank you so much to all of you that attended via Zoom and those who attended via Facebook. And I want to thank the various panelists here and the questions. You will see that as SADA, and I'm going to ask Dr. Sone to close, you will see that as SADA, our interest is not self-gratification. It is about the profession at large. And with the DPCOM, with the chairperson, Dr. Swanepoel, the board, if there is constructive criticism, bring it on, because it will only serve and help the profession to grow. And if you've got issues that you want us to handle, my door is open all the time. There's not a single person that I do not deal with. There's not a single person that I will avoid. And I prefer the big issues I will deal with. I go head on. I have no issue with that. That's how I am. And if anything that can take this profession forward, please bring it on. Let's work together as a unit, and we will be able to change the profession. Prof, last night, actually, and that's why this whole thing comes up again. He mentioned that over these years, we have allowed medical aid schemes to actually walk over us. And that's exactly what I said 3 years ago. So, guys, let's work together. That's all I can say. Let's forget about this professional jealousy and people wanting to be individualistic. Let's stand together as a profession and we can achieve more. Dr. Swanepoel, can you please say a few words and close this meeting? Thank you.
Casey, thank you. I just want to thank you for your passion for our profession. And I think the people on the webinar saw it tonight, and that's what you've said. Your door is always open for people to come to talk to you. And please, I ask everyone that if there's any suggestions, contact us so that we can work from there. But I definitely want to ask the profession that we have a look at not being dependable from medical aids, because then we're just going to, as I've said, when we started just after the COVID-19 lockdown started, I made the comment that Dr. Hyde made years and years ago. If we're not going to swim together, we're going to drown separately. So I've asked you, let's start swimming together. Thank you everyone for listening to us tonight. Enjoy your week and best of luck.
Thank you. The meeting is adjourned. Thank you very much, everyone. Good night.
Good night.
Good night.
Bye.